Okay, good afternoon, everyone. My name is Elena Kussler. I'm the program director here at the Parkinson Association of the Rockies. I want to thank you all so much for joining us today and thank Dr. Korsmo here for presenting on an overview of medications. I know it's a popular topic, so we're excited to have you. A couple of things to go over before we get started. We'll go to my next slide. So we will be having a Q&A session at the very end of the presentation. There are a couple of different ways that you can ask the question. The first, if you navigate to your control panel, there should be a little questions tab that you can click on and type your question in there. Those questions will come directly to me, and at the end I will pop back on and ask those for you. The other option is if you would like to ask your question verbally, you can unmute yourself. I'll call out your name. You can unmute yourself if you raise your hand. There should be a little raise your hand icon that you can click and I'll unmute you, and then you can ask your question directly from there. So another note, this presentation is recorded. So if for whatever reason you're not able to sit through today or your internet goes out, there will be a recording of this available in a follow-up email that will be sent out tomorrow around this time. Or we will have it available on our YouTube channel within a day as well. So if you want to send it along to anybody, feel free and you can find it there. The last little bit is there is a survey for the presentation at the end. It will pop up on your screen, and if you would just take a couple of minutes to fill that out, it'd be very much appreciated. It helps us to develop our programming and make sure we're getting what you want in terms of education. So another tiny little thing, we do have quite a few upcoming webinars in the month of March, almost one every week with the exception of next week. This is just a quick list of all the ones that we have coming up. If you're interested in attending any of these, you can find them all and the registration link at www.parkinsonrockies.org/educational seminars. So go ahead and check that out. I'll also have that link up in the follow-up email sent out tomorrow. So keep an eye out for that. Sign up. We're happy to have you. So with that, I will go ahead and transfer over the power to you, Dr. Korsmo.
Okay, let me get it into presenter mode. And can everybody see? No, that's presenter mode. Let's see. How do I do this? Okay, how does that look?
Looks great.
All right. I think I'll go ahead and get started if that's all right. Hello, everybody. My name is Michael Korsmo. One of the fellows training here in movement disorders at the University of Colorado, specifically based out of the Anschutz campus. I did my training down in New Orleans at Tulane and then finished up my residency in Pittsburgh, and I'm really happy to be here and really appreciate the opportunity to speak to y'all, and kind of sad that I can't see anybody's face, but that's okay. So today we're going to be talking about medications used in Parkinson's disease and also a little bit of information on alternative therapies or advanced therapies. Right. This is going to be our goals. I know that this is a huge topic and it would be very, very easy to get into the weeds. So we're going to try to stay focused, and I'll be kind of reminding you and highlighting sort of the high yield parts of this talk. So number one, we're going to be reviewing really, really basic pathology of Parkinson's disease, a little bit of anatomy. And then that's going to allow us to sort of build up our groundwork and understand basic principles of treatment and how medications work. Then we'll probably breeze through pretty quickly each kind of individual treatment option under certain categories. Because again, I don't want to linger too long. This is more of an overview. And then I'd like to finish up the talk with clarifying some kind of common questions or misconceptions. And then what I think is probably most pertinent to most folks would be how to use your visit and your limited time with your doctors really effectively. So I've got some like high yield keys to an effective visit, and I think hopefully that will be helpful. So I'd imagine a lot of people here have a pretty good understanding of Parkinson's disease, but just to make sure everyone's on the same page, let's walk through that. What I'm showing you here on the left, and that gentleman, it looks like there's like a slice through his eyes and the back of his head. And that's kind of showing us how the slice on the bottom left is oriented. So that would be called an axial cut. And we're specifically focusing on the deep structure. It looks like Mickey Mouse, and that would be the midbrain. And the midbrain sits deep down in the brain brainstem. It's just one part of the brainstem. Brainstem has tons of important functions and structures. This is where all the nuclei that control facial movements and hearing and sensation and consciousness to agree all sit there. And then obviously everything coming down from the brain through the spinal cord into the nerves and muscles has to pass through there. So very, very important and crowded real estate. In the top right, you'll see a blown up section of that Mickey Mouse midbrain. And what's highlighted there are those dark strips, and that is the substantia nigra, named because you have melanin-rich neurons there that kind of give it that dark pigmentation. And this is exactly pretty much what it looks like if you were to take a look at that in real life on autopsy. And those neurons are heavily, heavily dopaminergic, meaning they produce a lot of dopamine. And what happens in Parkinson's disease, the kind of end result of a cascade of things would be cell death of those specific neurons. But it doesn't stop there, because those are the neurons that kind of just produce the dopamine. And ultimately, dopamine is what is deficient in Parkinson's disease and other diseases like it. This is a different section of a brain. So we're kind of, I don't know if you can see my face on this feed, but we're kind of cutting right between the eyes and again going back in what would be called a sagittal section. That midbrain, if you look down, is that area that kind of almost looks like the top of a bird's head, like a hummingbird, and it comes up, and I guess you can see my mouse here. This whole area is the midbrain. And so what this is showing you is that those dopaminergic neurons that are dying, they project out to a lot of different places and do a lot of different things. So for example, if you're looking at this, these are just fancy terms, but mesolimbic pathway, this is projecting up into the limbic system. That stuff goes awry in certain psychiatric conditions, and we focus on this pathway in red, which projects up and gives dopamine to the basal ganglia. And the basal ganglia are these deep structures in the brain that are responsible for movement. They're old structures evolutionarily, but extremely important. All right, let's zoom way, way, way in and make sure everyone's on the same page with how kind of a basic neuron is laid out. And this is pretty simplified, but here's our cell body. This is the body of the neuron. It has these little projections here called dendrites, and you can think of this as kind of the receiving end of the neuron. And what do neurons do? They talk to each other, and they send projections out this way through long axons, which can extend extremely far, and they ultimately terminate in these little buds which contact other neurons. And that where that interface is would be called the synapse. And let's zoom in on that. And here's where the dopamine comes into play. So backing up for a second, how do we transmit signals? How do these neurons talk to each other? Well, they actually use a pretty complicated system of ions and proteins that ultimately generate an actual electric signal. And that signal zaps down here and ultimately causes neurotransmitters to be released, and then that's what stimulates the next neuron in the chain. There's a variety of neurotransmitters in the brain, like serotonin and norepinephrine, but we care about the dopamine for this talk. And so first you have to make the dopamine, and it's converted through a couple of steps and precursors. It then gets packaged into these little bubbles, which are called vesicles. And when you get a stimulation, they migrate to the end of the axon, fuse, and then dumps the contents into the synapse. So now it's free floating. Then it plugs into what's called a receptor. And you can think of a receptor as like a lock, and the dopamine's the key, and they're specific to one another. And there's different receptors that do different things, but ultimately they will then go on and transmit further on the signal. Okay, then what happens to dopamine? Well, it can be taken back up into that neuron, and it can be recycled or broken down. And it can be broken down in two ways. One, by an enzyme called monoamine oxidase. We'll call that MAO from now on to keep things simple. And then the second one is called catechol methyltransferase, or COMT. And these enzymes are distributed widely throughout the body. This is just kind of a different cartoon representation of everything we just talked about. And let's break it down even further and keep it super, super simple. So we're going to kind of keep coming back to this picture over and over again throughout the talk so that everybody really understands what these things are doing. So we've got a mailman, and they're the neuron. Dopamine here is represented by a little piece of mail. Ultimately, the goal is to transmit that message on the mail to the target neuron, or the receptor, which is the mailbox. And then you can have two different mechanisms for breaking down the mail. One, you could have a paper shredder, and that's that enzyme COMT. And the other one would be this like angry dog that hates mail, and that's MAO. Okay, so understanding that kind of basic background information, what are at least theoretical treatment options, walking through them one by one? Well, the most obvious one on the far left here would be to just replace more dopamine. So you're low on the dopamine tank, pour more in. That seems reasonable. Number two, you could figure out how to prevent the breakdown of dopamine, make it hang around in the synapse a little bit longer. Could there be a way that you could just stimulate the receptor and bypass these two steps altogether and keep the signal going? I'll skip ahead to number 6. Could you modify the neuronal circuitry? So as I said before, there are electrical signals involved in these circuits, and can we tap into those in any way? And then 4 and 5 are theoretical, and we can't really do them yet. So would there be a way to protect dopaminergic neurons from dying in the first place? Maybe in the future, we're working on it. And then number 5, would there be a way to regrow dopaminergic neurons? And again, that hasn't been borne out in any way just yet. But again, maybe in the future, we're working on it. So down here, this is kind of in reference to 4 and 5. There are not any cures for Parkinson's disease. And there are no medications or treatments per se that can really slow the disease's progression, although exercise can, and we'll talk about that a little bit later. A big takeaway here, a big high yield pearl, is that medications treat symptoms, and that is it. Okay, so replacing dopamine, what does that look like? Well, just add in more pieces of mail like this with Levodopa. Or you could stimulate the dopamine receptor, and I kind of think of that as junk mail. It's not really correspondence. It doesn't carry any useful information, but it can still get into the mailbox and bother you. So with regard to those treatment paradigms, what options are there? Well, the main one, excuse me, the main option would be to simply replace dopamine, and that's where Levodopa comes in. And we'll talk more about what that is and how that works. And then you can stimulate the dopamine receptor with what are called dopamine agonists, medications including pramipexole, ropinirole, retigaine, apomorphine. Those are all dopamine antagonists. They're that junk mail. How about medications to block the paper shredder, which is COMT, or block the MAO? Again, these are the enzymes that break down dopamine. If you block those, you could theoretically have dopamine hanging around longer. So the Compt inhibitors, we have entacapone, tolcapone, and there's a newer one called opicapone. And then for MAO-B inhibitors, we have classically rasagiline, selegiline, and there's another new one called sulfonamide. Lastly, would there be a way that we could modify neuronal circuitry? Could we zap the neurons? Is there some kind of a surgical technique we could use? And the answer is yes, and we're going to talk about those later. And I think I already talked about this, but is there a way to stop cell death in the disease? No. But there's actually two really good trials, SPARKS trials, and I think there's another one ongoing right now, which have demonstrated in cohorts of Parkinson's disease as compared to other folks with Parkinson's disease that exercise, vigorous exercise really can change progression to some degree. Regrowing dopaminergic neurons, that would be like looking into stem cell research, and that's been a bit disappointing, but still working on it. So this slide is kind of busy. It has a lot of different medications on it. It's not meant to overwhelm you, but to just kind of give you a sense of the armamentarium that we have at our disposal. So under carbidopa, levodopa, that's how we're replacing dopamine. And all of these are just different ways of getting the dopamine in you, or these are different release types. Like some are fast acting, like your classic Cinemet or carbidopa, levodopa IR. And then there's longer release forms like Rytary, which is newer. We could talk about that. There is an under the tongue dissolving tablet that's called Parcopa. That would be used maybe more as a rescue medication. We'll get back to that as well. And then there's even a gel for use with a Duopa pump. We'll talk about that also. Under dopamine agonists, we have quite a few options. The main ones we use would be ropinirole, pramipexole, and retigotine. Under Compt inhibitors and MAO inhibitors, these are the two enzymes, again, that break down dopamine. We can block those with tolcapone, entacapone, opicapone, and we can block MAO with selegiline, rasagiline, and sulfonamide. These are other options we have. They're not necessarily part of that kind of paradigm we've already discussed, and that's because they are for more specific indications. So if you've heard of amantadine being used, we try to use that to help with dyskinesias, which we'll kind of define later on. There are anticholinergic medications. Artane and Cogentin would be the trade names. Those are specifically for tremor. And then there's a new medication called Neurians or istradefylline, which is specifically used in reducing off time. So replacing dopamine, let's talk about levodopa. Why couldn't you just take straight dopamine? The problem with this is that dopamine, if given orally and kind of dissolved into your systemic bloodstream, it's not going to be able to get into your brain. And this is because elsewhere in your body, at other target organs like the liver or the heart or muscles, what have you, a lot of these molecules and nutrients and oxygen can freely cross the capillaries, which are small blood vessels, and just get to the target organ. And that is not the case in the brain. In the brain, you have a highly selective barrier called the blood-brain barrier, which regulates what can and cannot cross. And that's a pretty nice feature if you've got, such an important organ sitting up there, making sure that you are very selective about what can and can't get into the brain. So how can we get around that? Well, the way you can get around that is by taking a different form of dopamine, like a precursor called levodopa. And so that's L-Dopa here. So this would be kind of your peripheral blood, we'll say, or a capillary. Here's our blood-brain barrier. And then here is one of those axon terminals. So levodopa, you can take it orally, and it's going to cross that blood-brain barrier. It's going to get converted in the brain into dopamine, and then it carries on with its normal functions. What you'll see is that for all forms of levodopa, it comes along with another drug called carbidopa. That's why it's so difficult to say, carbidopa, levodopa. And the carbidopa is an interesting add-on because it prevents L-Dopa from being converted into dopamine outside the brain. And that's good for two reasons. Number one, it's nice because it kind of maximizes how much of this L-Dopa is going to get to the brain. And number two, dopamine out peripherally in the rest of your body can wreak havoc. That could be why folks early on, before these two medications were given together, had significant nausea, low blood pressures, etc. So carbidopa, levodopa. Before we move on and talk a little bit more about kind of the kinetics and the dosing of it, let's just make sure we kind of have a shared vocabulary. and a lot of you are probably very experienced with this. Let's start with Parkinsonism. Parkinsonism, that would be the symptoms of Parkinson's: the slowness, the rigidity, the gait problems, walking, and sometimes tremor. And so when folks are saying off, they're meaning more of those symptoms. And when people say on, I'm feeling on, that's less of those symptoms and feeling overall good. Here's what it looks like in your blood when you take some form of L-Dopa. So kind of on this axis, this kind of roughly is approximating your serum concentration of that medicine. And then it's also showing you that it fluctuates. And this is why you have to take at least usually 3 doses of carbidopa levodopa in a day, because you take a dose here, the level rises in your blood, it peaks, and then it starts to wear off. And then you have to take a second dose, and it slowly peaks, and then it wears off. And as long as this is kind of fluctuating in this Goldilocks zone right here, people are going to feel pretty good. They're going to feel on. If, for example, you drop into this zone, that's when you might feel off. You might feel it wearing off, slower, stiffer, overall worse. Conversely, if you peak too high, if you're getting too much medicine, you can get into this trouble zone here where you can get dyskinesias, which we will again define later, but I guess I'll pre-discuss it now. Dyskinesias are slower, writhing, irregular movements that you can see later on in the course of Parkinson's, and they can fluctuate. Ideally, really the holy grail would be to figure out some form of levodopa that you could take maybe orally and would stay perfectly level like this in the bloodstream. That's really what all attempts at creating different levodopa formulations have been getting at. So different forms. So most people start out on this one, immediate release, and that works just fine. It's usually like 3 times a day, and you can make adjustments. The CR, controlled release, that was kind of an early attempt at a longer acting form. It didn't quite pan out that way. The kinetics of how it peaks and falls can be a bit unpredictable. So we kind of reserve this for special use cases. There is a medication that's a combination of not only carbidopa and levodopa, but also entacapone. And entacapone is going to be a Compt inhibitor, an inhibitor of an enzyme that breaks down the dopamine. But now we have a new form called Rytary, and this is really a true extended release form. Kind of interesting because it's a capsule, and inside the capsule we've got all these little micro beads, and each little micro bead is kind of a different form of carbidopa levodopa, and they are all going to rise and peak and fall differently, such that overall it's a longer acting formulation, which is pretty interesting. We're not going to linger on this slide for too long, but if you look at A over here, we've got on the y-axis levodopa. This is like the serum concentration, and then we have hours from when you took a dose. And each one of these little lines here represents a different form of carbidopa levodopa, with the ER form, which is Rytary, being these little circles here. And as you can see, it peaks pretty similarly to all other forms, but overall that serum level is staying higher for longer. Trouble with Rytary, which is the trouble with all new medications, it's new and there's not a generic yet, but we're finding we're able to use it when we need to through some patient assistance programs. There's some wackier versions being developed, which are kind of interesting. This is this accordion formulation, which sits inside a capsule, and you take the capsule, that dissolves and releases this little accordion structure, which kind of just not really gets stuck, but sits in the stomach for a good while and slowly releases different formulations of carbidopa levodopa. Ultimately, this dissolves. So that's around the bend. Here's another new form. This is actually an inhaled form of carbidopa levodopa. However, this isn't really used as a maintenance medication. This is more one of those rescue medications for folks who have sudden and really severe off time. They could try to take a puff or two of this to come back on quick. We use this here and there, but honestly, it probably doesn't come on that much faster than just crushing a tab of Cinemet or taking one of those dissolving tabs. Also, it can be a bit finicky to set up, and if you're off and frozen, that can be a problem. But we are using it, and some people really like it. When do you need to make dose adjustments to carbidopa, levodopa? That it sometimes seems random and kind of all over the place. We have to start making adjustments when people fall out of this Goldilocks zone. And what this slide is really showing you, if you kind of back up here for a second, is that this Goldilocks zone of feeling on with regard to how the medications are acting in the bloodstream, that gets narrower and narrower as the disease progresses. So later on, you're more likely to get dyskinesias and off time despite the same dose. So that's when you might have more frequent dosing in, higher dosing overall, etc. I don't know if I can pull this up right now. I'm going to skip this for right now. If you all want to see a video of a dyskinesia, I would be happy to provide that at the end of the talk. But again, this is slower, writhing, non-pattern, non-rhythmic movements that can come as a result of disease progression and usually are accompanied by taking levodopa. But let's talk about that because that can be a hot topic for some people. So right here, we're looking at a little figure from a NICE study that took a group of Italian people and people from Ghana and compared them. By the way, each group had Parkinson's, and the big difference between the two groups was when they started levodopa. So this dark blue here kind of represents time to when levodopa was started, versus down here, if you look in the Ghana group, their levodopa was started much later in the disease course for a variety of reasons. And ultimately what they tracked is when does wearing off and fluctuations occur in relation to that start time, and when do dyskinesias come? And ultimately, even though you see a little bit of shift here, none of this was statistically significant. And so we're trying to tell you that dyskinesias, they are a factor of disease progression. And earlier start of levodopa doesn't necessarily cause them to occur earlier or bring them on earlier. And then lastly, you've probably talked to a couple of people or have experienced yourself that dyskinesias, they're really only a problem if they're bothersome to you. Most folks are going to experience them to some degree, and sometimes they are so subtle that you really don't even notice them. Other misconceptions, let's kind of just go through some common questions that I hear about in my clinic, specifically with regard to levodopa. Can levodopa contribute to disease progression? And the answer is no. Can it slow disease progression? No, we already kind of established that. Is there any benefit in delaying the levodopa or kind of saving it up for when I really need it? Absolutely not, there is not. Do escalating doses of levodopa mean I'm developing some kind of a tolerance? Like, why am I needing more of this? Why am I needing dose changes? And if you look down here, again, that is because of disease progression. If I start levodopa earlier in my course, will that make it less effective later on? No, for the exact same reason. Common side effects. Again, when I discuss side effects, I'm discussing common ones. Lightheadedness, and it can exacerbate pre-existing issues with blood pressure. People can have a little GI upset or nausea with it, and it can potentially exacerbate hallucinations later on in the course. But again, overall, really well tolerated early on. So let's move on to stimulating the dopamine receptor, the dopamine agonists. Lots of choices here. You've probably heard of ropinirole, pramipexole, retigotine. They can be used at any time, and theoretically, it's kind of a smoother level of stimulation. But the side effects are of concern. So they can also cause low blood pressure, issues with hallucinations, sleepiness, or even sleep attacks where someone just suddenly abruptly falls asleep. The big one that a lot of movement disorder specialists and neurologists are getting a little more concerned about is impulse control disorder, which can accompany it. And impulse control disorder is really any exacerbation or a new impulsive behavior that is, maladaptive and not typically something that would be considered normal, like excessive gambling, losing all of your money, infidelity, buying a bunch of cars, raiding the pantry, hypersexual behaviors. While it's not necessarily common, it can just be so disruptive to people's lives and finances that we really, really like to keep an eye on that when someone is on a dopamine agonist. Again, this is the part of the talk where we're going to kind of breeze through a lot of things here quickly, just to kind of give you a feel for the options. There are long-acting forms for these dopamine agonists, which can be convenient, dosed one a day. Apomorphine, this is an older medication and initially used, again, for a rescue medicine if someone suddenly is off, because you can come on and it kicks in so quickly. The problem is that it can be unpredictable in how it kicks in, and it can have some nasty, pretty significant adverse effects that you do see, like really bad nausea and vomiting, or hypotension, which is low blood pressure to the point that somebody passes out. Even before you use one of these or a different formulation, before the first time, you actually have to pre-treat with a nausea medicine for a couple of days. There's a newer form of this, also meant to be a rescue medication. It's kind of like one of those mints that dissolves on your tongue. It looks like a piece of tape called Kenmobi. And then let's talk about the blockers of the enzymes that break down levodopa. Here we go. So Compt Inhibitors, the big three would be entacapone, tolcapone, and opicapone. For the most part, we stick with entacapone. Side effects, they're pretty much the same as levodopa because if you were to take entacapone on its own without carbidopa-levodopa, it wouldn't do anything. So it's just kind of prolonging how long the levodopa hangs around. So the side effects are kind of the same as what you might get with levodopa. You can get a little bit of GI upset, and then it can turn your urine orange, which is just something to be aware of so you don't panic if that happens. MAO-B inhibitors, options are rasagiline, selegiline, and a newer one called sulfonamide. Side effects, they can be slightly activating, and this is one of those scenarios when we can use that to our benefit. So for someone who's maybe having some energy issues earlier in the day, this is not a bad add-on. You will read about the serotonin syndrome issue, which would be using an MAO-B inhibitor in combination with medicine acting on the serotonin syndrome. Frequently, these would be like medications for depression and anxiety. That is probably overblown in the literature, as these are kind of newer forms of MAO inhibitors. So it's more, again, a theoretical risk. Now, these can interact with other over-the-counter medications, specifically cough medicines. So we just always remind our patients who are on these MAO inhibitors to run that by a pharmacist if you're ever picking up over-the-counter cough medicine. You may also read about this thing called a tyramine crisis. This is with older versions of MAO-B inhibitors. There was a theoretical risk of getting an unusual syndrome if you mix this with aged foods and cheeses and wines and charcuterie, but multiple studies have shown that this is really not an issue with these. And even with the older meds, you would have to theoretically eat your body weight in cheese or charcuterie, which would be very uncomfortable. We've got, again, a variety of other treatments for other motor symptoms like dyskinesias. You might hear of us using something like amantadine. Amantadine, however, it can exacerbate hallucinations and cognitive problems. We use what are called anticholinergic medications, specifically for tremor. Most of us don't use these anymore. And the problem is there's been some data that shows that this can bring on irreversible changes in thinking and memory later on, and even exacerbate thinking and memory early on in the course. And then lastly, dystonia. This would be like patterned, repetitive movements that are bothersome, like, for example, curling of the toes or in-turning of the foot. We can actually use Botox injections quite effectively to treat that. Like I said, a lot of the drug development lately has been kind of repackaging what we have already, but trying to deliver it in such a way that you can stay in that Goldilocks zone really nicely. And so that's where things like an apomorphine pump has been tested, so just a continuous infusion under the skin, or a Neuroderm patch. This is currently in clinical trial phase right now, where this little tiny pump is slowly, continuously feeding carbidopa levodopa into the skin to get more of that smooth, a nice theoretical response, so we wouldn't have those fluctuations. Currently, you can go out and get this now if you and your doctor want to. This would be called the Duopa System. And what's happening here is you have a pump which is containing carbidopa levodopa, slowly infusing that gel in through what's called a PEG tube. And the PEG tube goes through the skin and dumps right into the stomach, again, for a more continuous supply of that instead of these peaks and troughs. And then really briefly, let's run through all the other symptoms we treat, because as a lot of you know, Parkinson's is not just the motor features. We are more and more recognizing the non-motor features like depression and constipation and excessive drooling. And we like to ask about that every single time because there are treatments for it. One thing to mention is that most folks with Parkinson's disease, or really any neurodegenerative disease at some point, usually late in the course, are going to get some degree of thinking dysfunction. And there are some medications we can use to try to combat that. However, I'll say that they have been not necessarily the most effective, but reasonable to try. We frequently treat depression in our clinics because this is a prominent feature. About half of patients with a chronic disease like this are going to experience it. And we use essentially the same medications that we would use for depression if you didn't have Parkinson's disease. Psychosis, this can be kind of a scary one, but usually it's much later in the course and can be as subtle as misinterpreting an object in the night, maybe thinking a pillow on the floor is a dog, to much more well-formed visual hallucinations or even unusual thoughts. And here is where kind of our expertise comes into play, because certainly there's a variety of medications that can treat psychosis, but there's only a select few, and I'm kind of showing them here, that would be okay to use in Parkinson's, because most of these are acting on the dopamine system, and that's the issue in Parkinson's. REM Behavior Disorder. This is an interesting syndrome where the body sort of fails to disconnect from the brain when you're in REM sleep or when you're dreaming. And so this can be as mild as a little bit of movement in the night or calling out, to more extreme forms like thrashing, hitting your bed partner, falling out of bed. And you can see how that could be a potential safety issue and a bother to your bed partner. What's interesting about RBD, or REM behavior sleep disorder, is that it can predate the motor symptoms of Parkinson's by sometimes up to a decade. And it's very common. We have lots of treatments for this, but interestingly, our first line, kind of best tolerated, best medicine, is just the supplement melatonin. Orthostatic hypotension. This is the failure of blood vessels out in the body. It's a failure of those blood vessels clamping down when somebody stands up or gets up from bed. And you want them to clamp down because you want blood to stay up in your brain when you change positions. And when that fails, your blood pressure can transiently drop. And this can make people feel kind of lightheaded or dizzy when they stand up really quickly. And in more severe cases, you can just frankly pass out. So we have lots of non-medicine treatments, simple things like hydration, a higher salt content in your diet, and compression stockings. And then in more severe cases, we certainly have a couple of options here to help get people's blood pressure up when they need it to be up. This one is a little more out there, but we are seeing people have this done. Hypophonia, or a soft voice, is common in Parkinson's disease. And really the first line for that is going and seeing a qualified speech therapist who understands this LSVT program, or sort of training in being big and loud. As a latch stitch, there are some ear, nose, and throat doctors or surgeons who are willing to give collagen injections into the vocal cords to kind of bulk them up. And there's been some data that that helps, but it's kind of variable. Okay, interventional treatments. Again, not going to spend a ton of time here because this is not like the deep brain stimulation talk. We're trying to cover everything. So deep brain stimulation, this is a surgical technique where we implant an electrode into a deep structure in the brain, basal ganglia usually, and this provides continuous high frequency electrical stimulation to those target structures. And the two big things to remember about DBS or deep brain stimulation is one, it's reversible, so you can turn it off, you can take the lead out if you ever absolutely had to for some reason. And then it's adjustable, so as the disease progresses or changes, you can keep coming back to the doctor to have minor adjustments made. DBS is very effective, and it's been around for a while, since the early 90s. The technology has come a long, long way, and it's now been approved for essential tremor, obviously Parkinson's disease, and a couple of other indications. What you see here, this would be a typical lead. This is much bigger than it looks like in real life, but this goes down into the target area, and each one of these blue spots here would be a contact. And so this is one of the benefits of DBS, is we can choose where and how we're stimulating at different contacts, and we can kind of shape the electrical field here differently. Furthermore, we've got much more interesting and new electrodes that not only give us the ability to go up and down that lead, but around it as well. So we now have directional leads. And this is great when we're talking about steering the current toward an area that we want to stimulate and away from something that we don't want to stimulate. You really don't have to completely understand this. I'm just giving a flavor of all the different things we can do. So I just discussed that we can alter which anatomic structures we're stimulating, but we can change how we're stimulating. We can change the frequency, we can change the pulse width, so how long each of those pulses come, and we can obviously change the amplitude, which is kind of like how big those are or how much we're providing. Typical targets that you're going to hear about are the globus pallidus down here and the subthalamic nucleus, or the STN here. And all of these little structures down here, these are those basal ganglia that I was talking about at the beginning of the talk. Here's kind of what it looks like in practice. So you have a little pulse generator and a battery. This looks very much like a implanted defibrillator or a pacemaker, if you've seen one of those. This connects up to an electrode down deep in the brain. You have different leads that you can stimulate. And then again, just kind of showing you how far we've come. We've now got an example here of a physician programmer, which is a tablet, and they're wireless. And we do this programming in the office. And then even the patient programmers have changed. They're getting fancier and a little more easier to interact with. And the patient programmer is interesting because I can give patients different programs to switch between, or they can go up and down on stimulation or turn it on and off. So lots of options and functionality there. Just to kind of give you a sneak peek at what's around the corner, the way we're using DBS now, that would be called open loop. So you need a human being, like a doctor, to be able to program it. But in the future, we would hope to have implants that not only stimulate, but can listen to or read the activity that's going on in those structures, and then adjust and adapt to that, to the point that potentially someday you wouldn't even have the physician involved in programming. It would just kind of do it on its own, which is pretty cool. A lot of people are really excited and have heard about focused ultrasound. This is where you use an MRI machine to identify structures where we're going to direct focused beams of ultrasound. And where all those little beams converge, you get heat. And if you give enough heat, you burn. And so this would be an ablative procedure where you irreversibly burn a target. And this is not PD. This is kind of showing probably an example of essential tremor. but you get pretty quick results there. So what are the positives and negatives of focused ultrasound? Well, this is great for people who, for whatever reason, can't undergo DBS surgery. It's non-invasive, and then two downsides: it's not reversible. So if you were ever to have some kind of side effects due to the ablation, you can't really fix it, although that risk would, hopefully be pretty minimal. And then it's not adjustable either. So as your disease progresses, you can't necessarily make changes. Lastly, we'll spend the last few minutes here talking about how to maximize the visit with your doctor. So what does your doctor want to know? Well, first of all, right away, right off the bat, when you walk into the room or your doctor walks into the room, they want to know what are your goals and what are your questions. A bad time to ask, burning questions would be as the doctor's leaving the room. So getting that out in front really, really helps frame how things are going to go for the rest of the visit. We want to know if you're having any medication side effects, and we want to know the exact timing of when you're taking each medicine. And this is because we'll be asking, how do those side effects relate to the timing of your medication doses? We want to know if you're experiencing any fluctuations, like how much on time, how much off time, and again, how those fluctuations relate to your timing. Now, for some folks, this is easy. They have really, really good memories, no problem. But for other people, this can be a little more difficult to keep track of, particularly if you're taking medication 6 times a day. And that's why we really recommend keeping a journal. But then within that journal, being able to kind of zoom out and get the bird's eye view of what the pattern is. Your doctor also wants to know if you've had falls and under what circumstances. So are you tripping a lot? Are you freezing? Is there a trouble spot in your house? Or is it a balance issue, something completely different? Or were you up high on a ladder changing a light bulb, doing something you probably shouldn't have been? Your doctor wants to know if you're having any swallowing problems like coughing or choking. These are the two big safety concerns in Parkinson's, swallowing and falls. We'd like to know if you're struggling with constipation because we can help. And then all of those non-motor features we were talking about, we can help with, like sleep, energy, mood, and thinking and memory. So I took a little bit of time yesterday to kind of create a little template. This would be something that would be great if you were to come up with something similar on your own, or maybe some of the Parkinson's associations have something like this. If not, I'm happy to distribute this after the fact. But if you showed up with this piece of paper filled out and put it in front of me at a visit, I would know pretty much exactly what to do right away. And that would be great because then we could spend more time talking about what you want to talk about, counseling, doing a better physical exam, etc. So let's take a look at kind of an example of how you might fill out something like this. Again, you may adapt something similar at home. Obviously, your name and the date of your visit in case you're wanting to file this away, what your diagnosis is, and then again, right up top, what are the big questions and goals? So I wrote here, need help with sleep, and then can turmeric help with my PD? Here's an example of a medication table. This is so helpful for us to know what meds you're taking, what is the dose, and then when and how much you're taking of each. And I know that a lot of times a lot of different facilities will have like check-in procedures, or the medical assistant will come in and kind of go through your medications with you. But when medication regimens get so complicated, we really like to triple check. So try not to be too bothered when the doctor comes in and kind of wants to rehash it all. Side effects, I'm having some lightheadedness with position changes. On time, about 9 hours where I'm not feeling as slow and stiff. Off time, about 3 total hours in a day. And then what is off time? Because that can be different for different folks. So for me, it would be slowness and stiffness. How is the wearing off related to medication timing? About 1 hour before each carbidopa levodopa dose. No falls. Feeling like pills are going down slowly, but not coughing or choking. how's my sleep? And we want to know more than just saying sleep is poor. So I'm having trouble waking up and not getting back to sleep around 2 a.m. and I'm feeling really stiff when I'm trying to go to the bathroom. Mood is good, a little bit of forgetfulness, but not really impacting my daily life, not leaving the stove burner on. Constipation, about one bowel movement every other day, and having some urinary problems like urgency. I'll kind of finish here with a summary of what we talked about. There are a ton of pharmacologic options and surgical options. Every single one has its own use case, so don't be surprised if your treatment is different from your neighbor's. Each has its own specific side effects, and sometimes that's a bad thing, and sometimes you can leverage that and use it as a good thing. Treatments with medications are going to be accompanied by some kind of amount of experimentation, so don't get discouraged if you're having to try a couple of different things. And treatment's always going to be a moving target, and that's because we're dealing with a progressive disorder. And then lastly, I was spending that whole kind of last quarter talking about the keys to an effective visit. And that's because your doctor's recommendations, while we do a physical exam and that helps, they're really going to be only as good as the information you can feed to us. And then lastly, obviously, it's a relationship with your provider, and you got to work with your doctor to try to figure out the best treatment for you. And with that, I'll say thank you so much for your time and attention. And I think we have some time to open it up for questions.
Great, thank you so much for that comprehensive look at some of the medications available. There's a lot of information there, and so, and again, this information will also be available in a recording. So if you want to listen back and make sure you caught something, that'll be available later on. So really quickly, I'm going to go over some of the ways you can ask questions. You can either locate your questions tab on your control panel, wherever that is. Go ahead and type your question in there and I'll read it out. If you'd rather ask your question verbally, you can use the little raise your hand function and I will unmute you and you can ask that directly. One thing we do ask of you all is if you do have a question, please keep it high level. We want to make sure that the answer is applicable to everyone and not just to one individual. So with that, we do have a couple of questions in. The first question we have comes from Tom, and his question is, how do you think about optimization of nighttime medication doses to achieve best sleep results for someone early in the journey?
Okay, Tom, thanks for that question. I'm not sure specifically what aspect of sleep you're talking about, but I can kind of breeze through a couple. Number one, we discussed REM behavior sleep disorder, how that's very common in PD, and we're going to start with melatonin. If you want to get in a little bit into the nitty gritty, probably just going ahead and starting with an extended release form is going to be best. Because most folks who don't have PD, they're taking melatonin for a different reason, and that's to initiate sleep, to fall asleep. So it's going to be recommended you take the short-acting version like 1 or 2 hours before sleep. But we're dealing with REM sleep, which is later in the night, and so that's why that extended version might be more helpful. And then other sleep issues, there's a variety. There's diagnoses like periodic limb movements in sleep. There's straightforward insomnia, or sometimes it's just a factor of people wearing off and being just way too stiff in bed. And we can try to use like extra doses of long-acting forms of levodopa. That is like a whole talk in and of itself, sleep in Parkinson's. So I hope that was a little bit helpful. So really trying to nail down what features of sleep are you struggling with. That's going to help your doctor.
And we actually do have a sleep and fatigue talk coming up later this month, so check that out if you're interested. The next question, we actually have two coming from Carrie, are what treatments would you recommend for constipation?
All right, great question, Carrie. Very common problem. We start with just kind of simple over-the-counter tips or even dietary changes. So obviously making sure you're maximizing fiber in your diet, leafy greens. You can get that through supplements like Metamucil. There are over-the-counter options like milk of magnesia. which is just magnesium, which kind of keeps people nice and regular. Next steps would be more formal medications like Miralax or Docusate or Senna or Colace. And the choice for which one of those to use, again, is kind of based off a little more nitty-gritty details. But I think starting off with the lifestyle things would be most beneficial. Obviously, staying hydrated is helpful, but the goal is going to be 1 bowel movement a day. And the other goal is never being behind. So despite lots of people saying they might go 3 days in between bowel movements, then they're not having any issues, that might be fine, but you never want to get behind on constipation because you can run into serious problems. And we provide, like in our after visit summaries, a lot of those kind of lifestyle tips, and there's a lot out there.
Awesome. And she's followed up with a question about any new drug treatments for Parkinson's.
Yeah, so a lot of the treatments, I pretty much went through most of the big ones that are commercially available. Most of them are just kind of repackaging, rebranding of already available medications. But a couple of interesting newer ones. One would be istradefylline, which is called Neurians. And what's cool about that one is it acts in a completely different system. You can think of it as like acting in the caffeine system. And in some of the trials, probably overblown, but it's been shown to reduce off time by like 20%. So not a monotherapy, you wouldn't just like start somebody on that medication, but later on we've been trying it out. Anecdotally, it's been a little bit hit or miss. Trying to think of other treatments. Most of them are just repackaging of stuff we already have, like opicapone is a once-a-day version of entacapone, essentially, and much, much, much more expensive. But that's a whole extra talk about different medications and new stuff around the corner.
Yeah, for sure. I'm sure there's quite a few out there. Our next question comes from Maria, and she asks, can you advise of any foods to stay away from with carbidopa, levodopa, and amantadine?
And amantadine, well, great question, first of all. I don't think there's an issue with amantadine, so we'll push that one to the side. Carbidopa, levodopa, it's absorbed best on an empty stomach. It doesn't mean that you have to do it that way because some people might get a little bit of nausea and that's fine. But if you find that you're having some dose failures, meaning, gosh, every time around lunchtime when I'm eating lunch, that dose just isn't kicking in as well, then you might consider taking your dose like 30 minutes earlier. To be a little more specific, it's protein that's going to impair absorption of it. So eating a big steak and then taking your carbidopa, levodopa is not the best. If you have to get it down, that's fine. But that's just to tell you that if you need to take it with something for a little bit of nausea, maybe like crackers or something like that would be best.
I know that's a pretty common question we get, so thank you. And it looks like we have a hand raised from Mary, Mary S. If you want to go ahead and unmute yourself, you should be all clear on our end. Mary, are you there?
Yes. Okay. I was wondering about food at the time of dosage from your medication, because I seem to have a problem with that.
Okay. Did you hear my response to the last one, Mary?
I did.
Okay. Okay, good. Nice to meet you.
All right. So, okay, and then we'll go ahead and ask one more question, and this question comes from William, and he asks, when do you advise dopamine replacement versus an agonist?
I would say nowadays, and again, there's different ways to kind of skin the cat, if you will. There's so many different options that there are different practice patterns, and people are a little more comfortable with certain meds and not others. It can vary. But we used to that we needed to kind of conserve the levodopa. And so you would hear about, in older times, we would want to start people on the dopamine agonists so that we could like save up the levodopa. But all of the data has shown that that's just not true and something to worry about. So my go-to and a lot of the people I'm training under, their go-to would just be carbidopa levodopa. It's probably about 60 years old now, and it still works the best, and it's tolerated the best, and it has one of the best side effect profiles. And it would be nice if we could use the dopamine agonist more, but you'll notice that a lot of younger movement disorder specialists are shying away from it because you can have some of those issues with impulse control and withdrawal symptoms and hallucinations later on. So they have their place, no doubt, but not necessarily the first, drug we might go to. Oh, and when to initiate? Was that part of the question?
It's when, yes.
When, yeah. So it's first thing, if you back up for a second, none of the medications alter progression. They don't fix what's underlying the disease. They treat symptoms. So in a way, that means it's really up to you. So if you're bothered by your symptoms, we're happy to start you on medicine. I think the only time that your doctor is going to kind of push it on you a little bit more, say, I really want to treat you, would be if there's safety risks, like we're having some tripping and maybe a fall or some swallowing problems. That's when we might push the issue a little more. But across the board, most people, if they're advanced enough, they're going to feel better on treatment. And so they're going to want to get started and continue it.
We actually have one more question. Do you mind if we sneak it in?
Absolutely.
Okay, so this question comes from Charlene, and she asks, how do you dose entacapone?
Entacapone.
Yeah.
Entacapone, that's simple. It's 200 milligrams. It's one tablet, and you take it with every dose of carbidopa levodopa because it's an add-on, and it's keeping that medicine around longer in the body. So really simple. You just take it with every dose.
Okay, so I think that'll be all for today. Quick reminder, we do have a survey at the end, so please take a minute to fill that out for us. There will be a recording available for you around this time tomorrow, so keep an eye out for that in an email to you as well as on our YouTube channel. And with that, I want to thank you, Dr. Korsmo, so much for that very comprehensive overlook at medications. I know it's a lot of information to get in very quickly, so we really appreciate it.
All right, you're welcome. Nice to meet some of you.
Yeah, have a good one.